So it's my pleasure to introduce Dr. Aaron Tierney. He is a staff scientist and health equity and diversity scholar at Kaiser Permanente Northern California Division of Research. His expertise lies in the equitable design and implementation of both patient-facing and clinician-facing health information technologies. Dr. Tierney's research agenda focuses on health information technology, aiming to generate evidence to inform how to make these technologies more equitable, accessible, and usable for vulnerable populations. Currently, Dr. Tierney's work falls into three main categories: the assessment of the impact of ambient artificial intelligence, scribes on healthcare delivery, bias and fairness assessments of algorithms, and telemedicine implementation. He also currently serves as on the Diversity, Equity, and Inclusion Committee, the Nominations Committee, and the Advancement Committee at the American Medical Informatics Association. Um, so without further ado, Dr. Tierney, you can go ahead. Also, he said that you can ask questions throughout, so please feel free to interrupt. Thank you so much.
Yeah, thank you so much for that introduction. I'm going to share my slides really quickly. Um, okay, there we go. I'm here to talk to you about leveraging clinical informatics to advance health equity. And I'm going to start with kind of like a brief introduction, just to add on a little bit about myself and my work, and then I'll dive into two main projects that I'm working on right now that have health equity pieces in biomedical informatics. And so start off kind of as you already heard, my work kind of lies at this intersection of implementation science, health information technology, and digital equity. And so there's the three main buckets that you heard earlier. So what I'm going to talk about today is mostly my work in AI and predictive analytics. But I'm also happy to connect later on about telemedicine implementation work if anyone's curious, um, as that's a very interesting project that I've not been able to do as much while at Kaiser, but I still have that as part of my research portfolio and really looking at who is reliant on telemedicine to access primary care post-pandemic. And so a little bit about where I've been. I too have graduated from Columbia, but the undergrad in the Columbia College. And while I was there, I worked for 3 years in the Columbia University Medical Center, researching cognitive aging. So my bachelor's is actually in psychology, so I have a little bit less of a traditional path into biomedical informatics. Um, and then from there, I worked for a couple years in a joint position at Stanford Medicine in the Palo Alto VA here in the Bay Area. And that's where I started to get into researching like the interaction between the physician and the electronic health record and kind of how to build up that presence and maybe reduce documentation burden, reduce burnout for clinicians and increase like the patient-centeredness of care. And then after working at those two places, I did my PhD in health policy at Berkeley, where I also worked at the Center for Clinical Informatics and Improvement Research at UCSF while I was in my PhD. Um, and that gave me a great opportunity to really get hands-on and really get more in the weeds of designing digital tools. And finally, now I did my postdoc at Kaiser Permanente. It was a clinical informatics fellowship, and I was promoted a year early into staff scientist in my current role, and also named a health equity and diversity scholar at around the same time. That's my current position. And as you've heard, I also serve on the DEI committee at AMIA, where I work specifically on the advancement of anti-racism subcommittee of the DEI committee, and we connect with other organizations such as like Academy Health, if you've heard of them, or um, just try to like connect with also other places that support research in order to kind of build this unified messaging behind DEI and kind of disseminate it across different settings and different organizations. Um, as part of that work, I'm also on the nominations and advancement committee. So that means like I review the applications for our board, at AMIA if you are a member. So if you got a ballot and you were voting on that, I'm the person who reads through all these well, one of the people who reads through all those applications, and we meet together and select the final ballots, and then we send it out to all of you to vote. Um, and I really enjoy that work. I've been doing that for about 4 years, on five, going on five now. And so I think AMIA is a great organization. If you're not a member, I highly recommend joining and coming to at least our annual symposium, if not also uh, our clinical informatics. I forgot what the CIC stands for, but it's a great conference as well. And then so the first piece I'm going to talk about of my work is essentially health equity and large language models. And this is currently the main focus of kind of what I'm doing at Kaiser, and largely, as you'll see abroad, as part of my K award application that I'm in development, that's in development right now. And so for this section, I'm going to present some work that's under review. It just went through a revise and resubmit at the American Journal of Managed Care. And it's a thought piece for their special issue on informatics and other digital health technologies. And so when we were looking at this evolving landscape of large language models in healthcare, we thought it was important to kind of synthesize the main regulations and guidelines that are coming out to kind of guide healthcare organizations and other institutions in developing healthcare focused large language models. And so um, we compiled 8 major frameworks that we found, or regulations guidelines that we found that were really impactful and had a large reach. And so first one of these was the Office of Civil Rights' 1557 rule, which focuses on preventing discrimination based on race, color, national origin, sex, age, or disability. And it also contains specific requirements regarding individuals with limited English proficiency. However, it doesn't really provide any benchmarks or ways to how to comply with the requirement. And kind of leaves that up to the end developer or user. And the second bucket, we have the White House putting out an executive order on the safe, secure, and trustworthy development of the use of artificial intelligence. And this really focuses on responsible AI use and affordability of life-saving drugs in particular, but also discusses investing in the infrastructure necessary for large language models or AI innovation at large. And while it does talk about these things, it doesn't kind of address like how we should, which is a very important problem, how we should talk about how these models are developed, because a lot of large language models, especially to be very competitive or very accurate or very robust, cost a lot of money to train, develop, build the teams that can both develop these models, but also maintain them in a responsible manner. And that is a question that we have yet to kind of answer and struggle with, as you'll see in a future slide. But moving on to the United Nations, they put out this framework about seizing opportunities for safe, secure, and trustworthy artificial intelligence systems for sustainable development. And this is like a very US-led effort to create an international consensus on AI development and best practices. And it's still in its early stages and pretty broad and abstract, but it does contain some very interesting guidelines on how that could have a global influence. And the National Academy of Medicine's AI Code of Conduct uh, looks at best practices for applications of AI and healthcare and biomedical sciences. And this is highly grounded in research, kind of unlike the upper three. And at the time when I was writing this piece, it was still in kind of a draft process and still more abstract with less concrete recommendations. But this could be very interesting if you for like especially for the more research heavy side of large language model development. Um, and the second half of these regulations and guidelines, we have the Light Collective. which I've been talking to more in depth recently with. And they're a really cool organization that is all about including patient rights and patient voices in AI and large language models development. Um, and they really talk about the need for transparency, and they outline how to essentially incorporate patient voices into development and implementation of health AI. And I really see the synergy here where this can be paired with the National Academy of Medicine AI Code of Conduct to really create this comprehensive set of AI recommendations. Um, while this does address a key gap, there still needs to be something worked out on how to synergize this like very patient-centered framework with kind of the frameworks that we might see that guide healthcare organizations or um, physicians or clinical care teams to make sure that everything kind of like works together and that we have AI and large language models that work both for patients and the care teams that use them. Um, and in a similar vein to on the previous slide, uh, as an international guideline, we have the World Health Organization Health AI guidelines that the WHO kind of just put out to have a global focus and give some country level implementation considerations and talks about gaps between countries, especially since different countries are better set up to be more competitive in kind of this AI race to the top, essentially that's going on right now. Um, the one you might have heard of, the Coalition for Health Artificial Intelligence, or CHI, which Kaiser is a member of, uh, provide a framework based on existing standards for ensuring quality and ethics in AI in healthcare. And it covers the entire lifespan of an AI intervention. And it has 5 large domains, and there are very detailed checklists that are involved in each of these domains as well. Um, but kind of like that's both a blessing and a curse in that it does have a very comprehensive set of checklists, but also it can be kind of large and somewhat burdensome if you might be trying to use this in a kind of a fast-paced, fast-moving setting, at least as it currently stands. But I do know that this is constantly in development and modification as well. And then the final framework I want to mention, or final regulation guideline I want to mention is this developing, purchasing, implementing, and monitoring AI tools in radiology, which came out of an international coalition of radiology societies that talked about how to develop, tune, and maintain AI-based tools in radiology. So this isn't LLM specific, but it talks about this broader idea of AI, which includes imaging and other things too. Um, and this would require some tailoring for use outside of radiology, but radiology in particular has a very robust development of kind of AI regulation in general. And so we felt like it was important to include it in this thought piece. And so kind of in,
So, sorry, I have a question real quick, if you don't
yes,
mind.
yeah,
So, just a quick question with regards to, I think, the diversity of the guidelines.
yeah.
Was there ever any kind of like common links in terms of like the groups or bodies that would be, or the people just involved in curating each of those? Because some of them seem very domain or clinical specific. Some of them seem like they're broader in scope on a global level versus a national level. So, will there ever be like an overlap in terms of who, from a member standpoint, is on each board? Or can these kind of be thought of as like we have these distinctly unique bodies of people making each one, which introduces more noise when it comes to trying to standardize it in the first place?
Yeah, I think you hit the nail right on the head. I think there is a lot of problem with standardizing these guidelines right now. I think we are in the very early days of kind of trying to regulate this, like AI and large language models in general, in health, but also especially in healthcare. And I think this is something we're also dealing with at Kaiser ourselves, and we're trying internally to develop our own kind of regulations and guidelines about how to develop these tools, who's going to do checklists, who's going to monitor the outputs of these algorithms. And um, as far as is there ever going to be a universal standard? I hope so. I know that that doesn't always happen for these kind of regulations. And so it might be kind of like there might be general guidelines that people kind of agree on, and everybody uses that as like a base, but then they do kind of their own in-house monitoring. But these are conversations that I've been in a lot lately too. I also recently attended a summit for a health area, like in health-focused AI models at the Citrus Bonato Institute at UC Berkeley. And we were also dealing with this topic of like what does the future of AI regulation look like in healthcare? And can we make these universal guidelines? And I think that's very much a work in progress. I'm sorry that doesn't fully answer your question, but that's
No,
kind
no, no.
of,
It
yeah,
adds like, to the nuance of the problem space. So thanks
yeah.
for going into depth about that.
But yeah, so in summary, kind of like to as a quick summary, this figure kind of lays out the common threads, even if there aren't common threads of who's involved with making these regulations, they're common threads of kind of what they're putting out. And so what we saw as common challenges mentioned by all these regulations and what they were trying to address were into three main buckets: linguistic and cultural bias, accessibility and trust, and oversight and quality control. And so for linguistic and cultural bias, this is really important because there's limited support for non-English languages and limited ability to understand non-standard English for large language models currently. And kind of this is at like a fundamental level, and that even a lot of large language models that are trained in other languages are trained to essentially translate that language into English first in a kind of nuanced way, but then essentially then process it and put out an output and kind of go through another layer of putting it back in that language. And this can be a really complex process that really ends up in some messy and strange translations, depending on how it's developed. But important solution to this is to take meaningful steps to ensure access for patients with limited English proficiency and to ensure that these AI models used in healthcare are free of discrimination and integrate equity principles. So making sure that they're tested in the real world with patients who speak English as a second language or may have speech-related disabilities, just to make sure that we aren't kind of building tools that only kind of benefit those that already might have more privilege in a healthcare setting and getting proper care. And then as challenges in accessibility and trust are related, but there's unverified utility for patients with disabilities, and many of these AI tools and large language models at large. And there's unknown acceptability about utility among vulnerable, marginalized, and underrepresented patient populations. Um, we see a lot of kind of beginnings of people trying to involve patients in talking about AI in their healthcare and kind of surveying patients. And for instance, the Light Collective just recently did a huge survey of patients about their thoughts and feelings about AI as in their healthcare, as well as you see it in certain organizations that are published in literature as well. But they all these kind of highlight because there's very mixed kind of findings so far. Sometimes patients are okay with it, sometimes patients are not. A lot of it has to do with the framing. Like if you frame it as, oh, this is helping your doctor provide you better care, then patients are really on board with AI. But if you kind of just say kind of like a agnostic statement of, are you okay with AI being used in your healthcare? You get a lot more of the kind of negative responses back. And so a solution is to kind of keep working with patients and patient advocacy groups to ensure that AI tools are safe, accessible, and beneficial, and ensure that there's diverse representation in training data and the teams that are used to develop AI tools, because having those people in the room from the ground up, if you're building something, is a great way to kind of get a checks early on, because just by the sheer fact of having diverse set of voices in a room, you get a lot more kind of uh, interesting thought development, and you get a lot more concerns that might be brought up sooner rather than later, but based on different people's life experiences. And then finally, in this oversight and quality control, there is limited human oversight and a lack of well-defined metrics to measure output quality, which is something I've dealt with in my own work, that I'll talk about just a little bit. And in this process, it's really important to keep human oversight of AI tools in healthcare delivery. Um, and it's important to focus to make sure that we're using these tools to make workplaces more efficient and reduce administrative burden and kind of make providing and receiving healthcare a better experience rather than exclusively focusing on things like ROI or like can I increase efficiency purely. And this includes developing techniques to evaluate AI-enabled healthcare tools and check them against real-world data. And we've seen this in the literature and a couple of thought pieces that have been out recently, and that it's really important to check outputs of all models, including large language models, against real-world data to make sure your tools are performing as intended. And so zoom in on how my own work touches large language models. I'm going to talk a little bit about Kaiser Permanente's implementation of ambient AI scribes and kind of where my next steps are going to integrate kind of this health equity research piece into this work. And so, as a little bit of background, the Permanente Medical Group wanted to implement an ambient AI scribe to help address documentation burden and increase face-to-face time physicians spend with patients. This was across a wide range of specialties, and the goals were to kind of facilitate engagement, to aim for effectiveness, to enhance patient physician-patient relationship, and maintain while maintaining documentation quality, because it was really important that in enhancing like in removing some of this burden from clinicians, we also were keeping high quality records in the electronic health record. And so this resulted in a pilot phase through December 2023 that's currently published and has been covered extensively by folks like Forbes, the American Medical Association, STAT, Becker's Hospital Review. And in addition to kind of like sharing some of those results, I'm going to share briefly a little bit of an update too that has data through June 2024, just so you can get a sense of kind of like the longitudinal kind of performance and success that we've seen for these ambient AI scribes within the Permanente Medical Group in Northern California. And so during our pilot period, we saw about 3,500 physicians enabling the AI scribe, which has since increased to just over 4,000. We have about 6,000 physicians total and 10,000 licenses available. So this is a large portion of our physician population that has tried out at least this AI scribe tool. And we saw it in our 12-week pilot period, we saw about 303,000 uses. That since increased to 1.25 million uses and ever growing. And our top specialties that these AI scribe was used in was mental health, primary care, and cardiology. And that has since shifted slightly to include emergency medicine and replacing cardiology in the third spot. And so in the impact, we saw a significant reduction in time outside of the hours of 7 a.m. to 7 p.m. and time and notes per appointment for physicians doing documentation who are using an AI scribe. We also saw high quality notes with little hallucination, and we tried to grade it with a modified version of this tool called the PDQI-9, which was originally used to grade the transcripts notes created by human scribes. And so we modified this tool slightly to be more relevant to an AI scribe. And you can see this figure on the left that's also included in the paper that looks at all the domains that we used, which ended up being 10 instead of 9. And we removed one that was more relevant to human scribes, and we added free from hallucination and free from bias for our AI-specific scribes. And as you can see, it was producing high-quality notes in almost actually in all of these domains. And in addition to producing these high quality notes, 71% of our patients reported that their physician spent more time speaking than normal, and 81% of physicians reported spending less time looking at their computer screen while using the AI scribe. Every single patient that we surveyed were neutral to very comfortable with having this tool used in their visit. And physician feedback was overwhelmingly positive and continues to be overwhelmingly positive that the tool is very helpful, especially for underappointments. And a little bit of an aside here, but our organization also recently overwent a vendor transition for our ambient AI scribe. So we switched who we were contracting to provide our ambient AI scribe services. And as you can see, the adoption is robust even through this vendor transition. So the blue line represents the number of notes generated by the ambient AI scribe in the first 8 weeks of wide-scale deployment for our first vendor. And our orange line is the same thing, but for our second vendor. And not only what I point out the number of notes generated, but also the slope of this line is much steeper for the second vendor, signifying this like rapid adoption, rapid uptake of this new kind of replacement tool that we've seen once we got it into physicians' hands. And so to address like the health equity piece of this work, I currently have a grant that has been successfully funded by this organization called the Dream CDTR. It's a collaboration between Kaiser Permanente Division of Research where I work, as well as Stanford and UCSF, and it is funded through NIDDKs. And this work is diabetes focused and links qualitative interviews with quantitative data about ambient AI script use for diabetes care. And so as part of the main focus of this work is going to be interviews with patients and physicians. And I've highlighted some of the domains of the interview questions that I'm really interested in on this slide. And I'm really interested in kind of both physicians and patients' overall experience, but also patients' awareness of these tools and what they are and how they work. Because I feel like that's a very important piece, as kind of highlighted by the Light Collective framework that I mentioned earlier. I also want to see if there are differences in use and effectiveness by protected groups or demographic groups. And I also want to see if there's differences in interactions with physicians for people who are using these AI scripts for their diabetes care. This includes looking at specific strengths and weaknesses for diabetes-specific care delivery, organizational integration and support, and on the organizational level, I really am interested in who are kind of our power users, but also who are our users who never try it and why, but also who's adopted or adopts it and tries it out maybe for a couple uses and then never uses it again. Because I also think that's an important piece to understand for future quality improvement of these AI scribes, but also how they can be modified in the future and adapted to better fit the physician user. On the patient side, I'm really interested in the comfort with ambient AI scribes, especially for patients who have reasons to historically distrust kind of not just the healthcare system, but also AI development and kind of these large technologies that are really based on having a large aggregation of data. I'm also looking for in these interviews for some suggestions to improve patient-centered messaging and disclosures about ambient scribes and AI at large, and patient concerns about these scribes and AI at large. And so before I move on, is there any kind of questions? Because I'm about to switch gears one more time to talk about some work in predictive analytics.
And there's a question in the chat.
Oh, yeah.
Yeah, I can read it out.
Is there a difference in AI scribe usage in inpatient versus outpatient setting? Yes, I would say that's definitely true. We're still in our early stages of understanding this. And oh, Um, and so we're in our early stages of standing. Is kind of what we've saw before, actually, with our first vendor was that ED was not a popular place to use the scribe. And but now the ED is a very popular place to use our new vendor. To give you like a sense of how that's rapidly changing. And also I've started looking at not just inpatient versus outpatient, but also telephone and phone appointments. And we're also seeing that while AI scribe usage is most robust in outpatient in particular and in in-person appointments in particular, there is a lot of usage still in the inpatient setting as well as for telephone and video. Um, uh, I think if I have, don't quote me on this, but from this recent survey that I was sending out, about 60% of physicians say they use it for telehealth, almost every one of their telehealth appointments. And so yes, there are differences, but I think we're just beginning to understand that. And I think it's also evolving as the tools get better and more useful for people as well.
Hi, Aaron. A quick question. So, um, I'm not as well versed in this, and I'm wondering, from a health equity perspective, for documentation of what the patient is saying, like, is the software robust enough to, for example, accurately capture the voices of people who have accents or, a different command of the language? Like, what is that like?
Yeah, that's exactly the interviews that I'm going to start in the new year are all about kind of like capturing that. We haven't heard too much about that so far from our overall kind of assessment. And so I am really interested in diving deeper into that because I do think there is a potential kind of for that information to get lost or kind of buried under the overall like really exciting things that are happening with these AI scribes. Um, but I would say that in other settings, I have heard some positive things about maybe not with accents, but being able to use the scribes in other languages. Because more and more of the AI scribe developers are making that a priority to kind of make sure their tools work in multiple languages. Um, and kind of, but on the flip side of that, it's harder to capture. Like for instance, in Kaiser Permanente, you're only allowed to use it in English, even though technically our vendor does have multilingual support. And so, but that's an organizational choice that we have made internally. And so that's kind of like a work in progress to see that, but I am very interested to see how well it performs across like different patient groups. Um, what's being done with the recordings used by the scribes? How long is this info stored and where is it being used for training future models? The answer is no. The recordings are stored for 14 days because there is a tool that's actually quite useful in this AI scribe interface that you can reference where the piece of the note is generated into line by line in the transcript. And so if you highlight a piece of the note being like, you said my patient said this or whatever, where are you getting this from? It'll cite back to the original transcript, which solves some of the problems because even though we didn't see many hallucinations in our pilot assessment, we did see, for instance, times where there was a separately hand examination of the patient's feet, and examination of the patient's mouth, and kind of the end note that this is prior to physician edit, but the end note that the AI scribe originally generated was that the patient had been diagnosed with hand, foot, and mouth disease, which was not an accurate statement, but kind of like pieced together because these three words were mentioned throughout the visit, and it kind of slammed together. So this new piece that lets us see where this is from is like a very important check that physicians are using to kind of make sure that everything is not that everything is being generated from factual data and things that actually happened and were mentioned in the visit. But it's only temporarily stored. It is not used for training of future models, and it is stored locally internally. at our organization. So I can't speak for how all ambient AI scribes work, but this is how the two that we have had work here. Are there risks with misuse and over-reliance with the scribe, where the scribe can potentially oversimplify medical discussions? I think yes. I think there are potentially a lot of risks we don't fully understand yet, and I think this is one of them that is definitely on top of mind. And I think kind of what we've had is like really driving home the need to kind of edit and to double check the AI scribe's work. Like this should not be an autopilot kind of process where people just push a button, copy and paste. It needs to be something that at least someone briefly reads to make sure that it's factually accurate and correct. Even still, and I would say like the transcripts that I've seen and worked on and analyzed have all been very, very highly accurate as an overall body. But to speak to your question, Yuta, it is very important to essentially maintain this human oversight, kind of how I mentioned in the first part of my talk with the health equity and large language models. I'll also say as part of this work too, not my own work, but just at broad, a large is there's also talks about using AI to generate physician messages, like answer physician questions. I mean, patient questions. Sorry, not physician messages, patient messages. To answer patient questions, and that is creating a whole new way of oversight and kind of like you do want to simplify that because you are hoping to aim for around a fourth grade reading level, at least for messages that you might be sending through AI to patients. But there's a whole bunch of like checks and kind of like in the development process that you have to do to make sure that you are simplifying, but not overly simplifying. So there's a fine balance here as well. Um,
Aaron, can I ask about
oh yes,
the the consent or the disclosure?
yes.
Tim Crimmins, I'm the CMIO here at Columbia.
Oh,
So can you talk a little bit about your consent or disclosure process you do with patients? And then I know you mentioned it as one of the things you're going to talk to the patients about to look for um, to evaluate equity. And can you talk about what you're thinking there?
yes. So essentially our consent process is in the room. I didn't go too much into this, but there's a whole training process to become an ambient AI scribe user. But part of that process is we've also laminated information sheets for patients that are in all of our rooms that patients might have an ambient AI scribe encounter. So it's pretty much everywhere in our setting here in Northern California. Um, and that gives a little bit of detail about kind of saying what the ambient AI scribe is and what it does, and also explaining to the patient they don't have to use this in their care at all. It's just a tool that's helping their doctor essentially take notes while they're talking. Um, and the physician also briefly goes over this with them as well when they consent them for recording, because a lot of this technology is used through our Kaiser Permanente encrypted iPhones that have linkages to Epic. And so a lot of the recordings are done with the microphone on people's like approved cell phones. And so that's kind of like the whole process that we go through. It's a very brief one. And we also have a dot phrase in our built into our EHR that allows for the physician to say that they did the consent very rapidly. And so it's recorded in the record as well that the patient consented for AI scribe usage. Does that answer? Oh, and how I'm thinking about health equity. Yeah, I think the way I'm thinking about health equity for this is that kind of my hypothesis is that there may be differential acceptance of this AI scribe usage by different groups. And I want to make sure that well, I want to see if that is the case, and if it is the case, why? And kind of like, are there ways we could increase confidence in the tool and its usage in the future, or are there ways that we can be more transparent that enhance patient trust in all across all patients in these tools, so kind of everyone can benefit if these tools are as promising as they are seeming to be so far.
Thank you.
Mhm. What frameworks are established for evaluating regularly the impact of predictive analytics on health equity? Oh man, I would say there's a mixed bag of kind of internal kind of developed frameworks in many places, and we at KP are also in the process or are very far along. I work with some of the folks who are developing these frameworks in-house for us on how to do algorithmic maintenance. You will see like some kind of publications out there also on this topic, and some of the ways of a regular evaluating impact are also mentioned in kind of those 8 frameworks or regulations and guidelines that I mentioned earlier in my presentation as well. But again, kind of to Adit's, I'm sorry if I'm mispronouncing your name, point earlier, there isn't kind of this like universally agreed upon kind of way of doing a lot of these things yet. I think we're still in the early stages of kind of analyzing these things. And for predictive analytics in general, I think for like more traditional predictive analytics, you are looking at things like area under the curve or like C statistics or things like that to measure their impact across different groups. But kind of the applications for health equity are a little bit early, but I will touch on kind of more of that in this next part of the presentation as well, kind of in my own work in perioperative medical appointments. And then I have another question that says, do you think patients will request AI scribes? What if the physician doesn't feel comfortable using them? That's an interesting question. I will say so far that is not what we are seeing. We don't see a lot of physician discomfort. It's actually kind of shocking how positive the feedback is from physicians about AI scribes so far. I think the more interesting one is to see kind of, as I mentioned, like patients. I don't know if patients will ever request an AI scribe specifically, but from what we are hearing, even patients who are kind of like, they've answered on surveys that they're neutral about the scribe, or they didn't really understand what it was doing, kind of like that, how it was helping, I should say. They were like, my doctor did spend less time looking at the computer screen, and they did spend more time looking at my face. And so I think even if they don't understand necessarily what the tool is and what it's specifically doing to help the physician, they do understand kind of those like basic, like, oh, my person-to-person interaction is better. My doctor spends less time typing and more time talking to me, and I feel more seen and have more of my concerns heard. And I think in that way, I think it's a jump to say patients will request it, but I do think that the patients will see benefit and notice the difference between their doctor using it and versus not using it. If I was throwing out a guess. Yes, it definitely does. And that's also why the recordings are not stored as well. Because there are some, and we have seen that not very many physicians, but we had a small handful of physicians in this survey respond that they were not using the AI scribe because of kind of like liability concerns, or like they didn't necessarily want things recorded. I think you also see for beyond liability concerns, just like privacy issues. And I think you'll also see that from patients as well. But also not accurately capturing what people are saying. I'm not sure if the patient necessarily noticed that is that often. That was something I would have to look more into, or others would need to do more research on. I will say that a lot of the feedback we've heard from physicians is that their notes are more accurate and more comprehensive. And they are capturing things that they would have forgotten. And kind of why, as I mentioned, especially in those long appointments that last like an hour, and you've covered so many things and a whole variety of concerns that go across the board, especially in primary care. And this is helping people remember, oh yeah, I did talk about that. And that is important to kind of like keep in the record. I hope that answers your kind of like follow-up question. Are there plans for transparent reporting of the findings and outcomes to stakeholders, including communities affected by analytics? Yes, I hope that that is kind of the future of all this work in general, is that not just in kind of like keeping open access to findings, but also kind of like reporting on these things to communities in more lay language and talking about like this is how, not just like what we find of like, oh, this is really helping your doctor, but also like this is how it works and this is why we're doing the things the way we are doing, and really engaging with folks and like walking them through these kind of like, these technologies and how they're used. Because while these aren't patient-facing technologies per se, and that patients are never going to be directly the ones that use them or activate them, it's their data that's being used to generate these transcripts. It's their conversations, it's their healthcare. And I think it's really important to kind of keep communities at large, but also individual patients involved in this process, and kind of how we talk with patients about using AI tools in general, but specifically AI scribes as well. Just in the interest of time, I am going to move on to talk about my last piece of health equity and predictive analytics, which I hope answers a little bit more of one of the questions earlier. And so as background, kind of as no surprise to anyone here, and kind of what we're talking about, we're currently seeing a rapid adoption of AI in healthcare. And this comes with a lot of promise, but also a lot of risk. And here at Kaiser, and hopefully in healthcare at large, we also want to focus on the responsible implementation of AI, which includes ongoing monitoring and the need to analyze impact on protected groups, even if an algorithm is not designed specifically to directly impact the care based on specific social demographic characteristics. To zoom in, we implemented the comorbidity assessment and surgical triage algorithm, or CAST, as I'll refer to it from now on, to predict the appropriate appointment length for pre-surgical perioperative medical appointments, or POM appointments. And this was based both on clinical risk and resource availability. And so it buckets the top 5% of patients in a high bucket, the middle 25% in medium, and the bottom 70% in low. And in our organization, the high, medium, low correspond to 60, 40, and 20-minute perioperative medical appointments. And in CAST, there were no social risk factors used to train the algorithm. And before the algorithm, we used a manually assigned surgeon-based complexity score. However, after the implementation of CAST, some physician feedback revealed that some patients needed longer visits than the algorithm was recommending, especially patients who needed an interpreter or had difficulty seeing or hearing. And so Timer was developed, and Timer was made to address this feedback that we heard, that certain patients needed longer appointments. And it is not designed to be used standalone. It is always designed to be used in conjunction with CAST, our original algorithm. And it predicts time spent in EHR performing actions related to palm appointments. That's what the data is that it's trained on. And essentially, I put this figure on the slide to kind of show how it works, but between a cast and timer, each one spits out its own independent recommendation of high, medium, or low, which corresponds to the 60, 40, or 20-minute appointment. And cast timer, the combined algorithm, essentially recommends to the physician whatever is the highest of the two of them. So if timer says that this patient is medium risk and cast says this patient's high risk, the recommendation that the physician sees is high. And so this work has two aims. The first was to assess changes in the probability of having a discrepancy between the predicted appointment length between the surgeon-based decision-making and cast, so our first algorithm. And this is by age, race, ethnicity, sex, neighborhood deprivation index, disability status, need for interpreter, and hospital frailty risk score, which is a score from 0 to 15. And the data for this project was pulled pre-timer implementation, so we were unable to assess the combined algorithm of cast timer for this first aim. But in the second aim, we examined the impact of adding timer to cast to create cast timer across protected characteristics and sociodemographic strata, which are, we use the same kind of assessment that variables for assessment that we used in our first aim. And this is retrospectively applied to cast timer because this was pre-official implementation of timer. And so in our first aim, we used logistic regression analysis to look at the likelihood that scheduled appointments are longer than predicted and or shorter than predicted. Well, not or and, but or shorter than predicted. And so this used a high versus a medium low kind of binary between these appointments. And we compared the odds of discrepancy for each approach. We also chose this because at a small selection of our medical centers in Kaiser Permanente Northern California, there's actually only 2 appointment lengths. There's like a 30 or 60 or a 20 and 40. And so this kind of dichotomization made a lot of sense in our setting as well. And for aim 2, we performed a logistic regression analysis for likelihood of shifting up, because you can only shift up risk levels between cast to cast timer because it always takes the highest. And so the likelihood of shifting up between cast to cast timer. And we also did a mean marginal effect estimation, which is based on logistic regression results, but it holds every variable but one variable at the mean, so you can see the marginal impact of belonging to a very specific group sociodemographically. And so the data that was used for this study were perioperative medical appointments happening between January 1st, 2019 and December 31st in 2023. This ended up being just over 500,000 appointments. And cast implementation date was May 1st, 2021. And again, any analysis of timer is retrospective. But what we saw in our overall sample is that our population tends to be concentrated in the ages of 40 to 79. It is predominantly Caucasian white population. And it is slightly more female than male, with about 4% of patients having a disability, 4% of patients needing an interpreter, and only about just over 1% of our patients falling into the highest hospital frailty risk score, with about 15% falling in this kind of medium range. And this is based on the literature on how to use the hospital frailty risk score. I did not come up with these kind of like these 3 buckets that you see here of 0 to 5, greater than 5 to 15, and greater than 15. And so what we saw is that the rates of discrepancies for protected groups varied by kind of social demographic groups, as well as these hospital frailty risk coordinated needs interpreters. And so where CAST was able to match traditional surgeon-based decision-making and predicting a long appointment was by race ethnicity for Black, Hispanic, and Latino, and other race self-reporting patients. disability status, need for interpreter, or the medium kind of hospital therapy risk score, where we saw a match between the short appointment lengths, so the low medium, between the algorithm and manual assigned appointment length was, again, for race, ethnicity, and for Hispanic and Latino patients, Asian patients, and patients identifying as other race, ethnicity, and the highest neighborhood deprivation index, so this fourth quartile. And where we saw a slight mismatch was the highest, for patients who are in the highest neighborhood deprivation index, they were predicted short by CAST, but the physicians were better at assigning these patients to longer appointments. And for patients who had the highest hospital therapy risk score or had a diagnosis of a disability, they were given a longer appointment by the algorithm when the physician would have assigned them a shorter appointment. And so patients from projected groups were more likely to shift to longer predicted appointments between CAST and timer across the board, including in those key groups that were mentioned by physicians as needing more time. So people who needed, so people with high hospital therapy risk scores were the biggest impact in the shifting, as you can see by the mean margin analysis on the right. Patients who needed an interpreter, which was an identified group that needed longer appointments by physicians, was also a major factor in shifting up. Being 60 or older was also a large factor in shifting to a longer appointment length between CAST and CAST timer. Patients who are African American or Black shifted at a higher rate to longer appointments, and patients with disabilities, again, another group identified by physicians by needing longer appointments, were also shifted at a significantly higher rate between CAST and this combined algorithm of CAST timer. And so there are varying levels of discrepancy between the surgeon and CAST-based predictions and scheduled appointments. And future work, we're hoping to include more analysis of CAST timer. But CAST timer so far seems to have the intended impact of increasing predicted appointment length for demographic groups identified by surgeons, especially as those needing longer appointments. It also had a similar impact for other predicted groups. And so in conclusion, despite not being trained on the majority of analyzed sociodemographic variables, the combined algorithms increased recommended appointment length for protected patients. Methodologically, this could highlight the utility of merging algorithms to mitigate bias and align performance with goals based on feedback, instead of having to de-implement and re-implement an entirely new algorithm. And future work should study the impact of integrating social risk factors into algorithms with clinical applications and assessing implementation of algorithms to ensure equity in care delivery. Very briefly, kind of where the future of this work is, my work is headed in this last couple minutes. I am currently trying to build up a simulation analysis demonstrating how traditional metrics such as C-statistics do not always accurately paint the picture, an accurate picture of algorithmic performance when it comes to health equity. For instance, in some populations in the Bay Area, you see that Latinx patients tend to be also younger. And so some of kind of historic things that might arise because of historic discrimination and neighborhood redlining are sometimes erased in our algorithmic predictions by age, because we say age, being young is good for your health. And so that erases kind of some of this variation that you see across different, there's many different nuanced ways this is happening, but these statistics aren't always painting the correct picture of care that patients need. And finally, I'm working on my K01 application to NIDDK to, as I mentioned earlier, to study the implementation, impact, and equity of ambient AI scribes for type 2 diabetes care delivery, to build more on those interviews and that qualitative mixed method, mainly qualitative, but mixed method work that I mentioned earlier. And thank you so much. I really appreciate you all having me here today. And Please feel free to reach out via email for any future comments, questions, or if you just want to connect, or if you want to learn more about AMIA, if you're interested in AMIA, happy to talk about that as well. So thank you.